Hey guys, welcome to Surgical Utopia. Today we'll be discussing about dentigerous cyst, which is also called as follicular cyst, and it is a developmental cyst formed by accumulation of fluid between the reduced enamel epithelium and crown of an unerupted tooth. It is the second most prevalent type of odontogenic cyst, the first one being the radicular cyst. Coming to the pathogenesis of dentigerous cyst, the pathogenesis is controversial, but it is believed that the accumulation of fluid either between the reduced enamel epithelium and enamel or in between the layers of enamel organ is the key formation of dentigerous cyst. The dentigerous cyst may be either extrafollicular or intrafollicular in origin, and there are three possible mechanisms for the formation of dentigerous cyst. The first one, according to this, intrafollicular developmental cyst may develop surrounding the crown of affected teeth. The second mechanism is that when the radicular cyst develops at the apices of a non-vital primary teeth, these radicular cysts will fuse to the follicles of unerupted successor of this primary tooth, and this will cause the eruption of successor tooth into the cystic cavity, and it will result in the formation of extrafollicular dentigerous cyst. The third possibility is that when there is periapical inflammation, which could be from any source, most probably from a non-vital deciduous tooth, it will spread to involve the follicle of the unerupted permanent successor of the primary tooth, and the inflammatory exudates will cause separation of reduced enamel epithelium from the enamel, which will result in the cyst formation. Next, we will be discussing the clinical features which can be seen in cases with dentigerous cyst. The dentigerous cyst will most commonly involve single tooth, but it may also involve multiple tooth in few cases. The most involved tooth is the mandibular third molar, then followed by maxillary canine, and it will be also related to supernumerary or ectopic tooth. Dentigerous cyst will occur most commonly in second and third decades of life. Age presentation of the cyst ranges from 3 years to 57 years, with the mean age of 22 years, and males are found to be more affected than females, and the ratio is of 1.8 is to 1. The lesion presents usually as a single lesion, but bilateral and multiple dentigerous cysts may rarely be seen. It is a non-aggressive lesion, and it may sometimes cause expansion of alveolar bone, displacement of teeth, severe root resorption, expansion of buccal and lingual cortex, and even pain if it is infected. In case if the cyst is present in maxilla, there are chances that the tooth may be displaced into the maxillary sinus, causing sinusitis, headache, and it may also be displaced into the nasal cavity. Histopathologically, we can see that dentigerous cyst will present as a loosely arranged fibrous connective tissue wall which contains glycosaminoglycan ground substance. Few islands or cords of inactive appearing odontogenic epithelial rests are usually scattered within this connective tissue, and most commonly it will be located near the epithelial lining. The epithelial lining is composed of 2 to 4 layers of flattened non-keratinizing cells with a flat epithelium and connective tissue interface. Radiographically, dentigerous cyst appears as a unilocular radiolucent area that is associated with just the crown of an unerupted tooth and is attached to the tooth at the cemento-enamel junction. The radiolucency is well defined and well corticated and often have a sclerotic border indicating bony reaction. But in case if it is infected, the cyst may display a ill-defined border. Radiographically, three types of variants can be seen. The central variant, and it is the most common variant, in which the cyst surrounds the crown of the tooth and the crown projects into the cyst. Then there is lateral variant. In this, the cyst develops laterally along the root surface and partially surrounds the crown, and it is associated with mesioangular impacted mandibular third molar that is partially erupted. The third variant is the circumferential variant. In this, the cyst surrounds the crown and extends for some distance along the root surface so that a significant portion of the root appears to lie within the cyst as if the tooth was erupting through the center of the cyst. The treatment choice for dentigerous cyst is enucleation along with extraction of impacted teeth. And in case if the tooth cannot be extracted, then orthodontic treatment may be sought in order to bring the tooth in a favorable position so as to be extracted, or if it is to be left in the position, it will be orthodontically moved to the favorable position so as to bring it in occlusion. In case where the dentigerous cyst is large, marsupialization can be done in order to decompress the cyst with a resulting decrease in size of the bony defect, and then the cyst can be excised at a later date, thus preventing very extensive surgical procedure. The prognosis is excellent and reoccurrence is rare. Sometimes there is a possibility that neoplastic transformation to an ameloblastoma can be seen, and it is documented that 33% of ameloblastoma arises from epithelial lining of dentigerous cyst. The differential diagnosis of dentigerous cyst includes radicular cyst, odontogenic keratocyst, unicystic ameloblastoma, Pinberg tumor, or calcifying epithelial odontogenic tumor, adenomatoid odontogenic tumor, and odontoma. So here we come to the end of discussion about dentigerous cyst. I hope you liked the video. Until we meet next, take care and bye bye.